Thank you very much, and thank you all for joining us for the webinar. I'd like to begin with a little history. I always feel comfortable knowing the history of things, and I'd like to provide you with the history of the checklist series. Well, can't seem to get these guys moving. Oh, there we go. I guess I didn't press the button hard enough. The very first self-report symptom inventory was a personal data sheet which was developed by Woodworth in 1918 at Columbia. And at that time, there was a huge shortage of psychiatrists in this country, and men were being evaluated for the American Expeditionary Force for World War I, and Woodworth got the idea of having, he said basically, let's have each man interview himself. And he developed this relatively brief checklist of symptoms. Not a lot happened in that field until the Cornell Medical Index came along in 1948, and that's 30 years. People used various versions of the personal data sheet through that period. The Cornell Medical Index was a medical systems evaluation, very comprehensive, and it had a one-page sheet with a bunch of psychiatric symptoms printed on it, and the respondent simply said they had the symptom or they didn't. Again, very little occurred there. I was astounded when in the 60s I was doing some research that required an outcomes instrument and went to the Cornell Medical Index, which was the only thing I could find. It did supply, because the items in the Cornell Medical Index were in checklist form, it provided the name for the Hopkins Symptom Checklist, which I developed in the late 60s. This is a sound five-dimensional test, as you'll see. But when colleagues helped me evaluate it, we came to the conclusion that it didn't have enough breadth in terms of the range of symptoms. So I added 4 dimensions after quite a bit of work and developed the SCL90R in 1975. That same year, the brief symptom inventory was developed. And then the final instrument in the series, the BSI-18, was developed in 2000. Again, having trouble getting this slide up for some reason. There we go. This gives you a kind of matrix of the instruments, starting with the Hopkins Symptom Checklist, going to the SCL90R, the BSI, and the BSI-18. The HSCL had 5 dimensions. The SCL90R and BSI both have 9 dimensions, and the BSI-18 has 3 dimensions. The BSI-18 has the somatization, depression, and anxiety dimensions. All of them have a global severity index, sort of total score measure. Okay. Now, I'd like to review the various dimensions of the 90 and the BSI because I learned the hard way. I thought everyone knew them all, and I was shocked to find that many individuals in the field never use these sets. So let me run through them with you quickly, and I'll let you read some of the definition, and I'll review it. Somatization reflects the stress arising from perceptions of bodily dysfunction. Complaints focus on cardiovascular, gastrointestinal, respiratory, and neurological, as well as other symptoms with strong autonomic mediation. And the definition goes on. obsessive-compulsive dimension focuses on thoughts, impulses, and actions that are experienced as irresistible and unremitting, but that are of an ego-alien or unwanted nature. In addition to the classic obsessive-compulsive syndrome symptoms, the obsessive-compulsive dimension also evaluates a general cognitive performance deficit that one sees in anxiety and depressive syndrome. Sorry. Interpersonal sensitivity is a measure that focuses on feelings of inadequacy and inferiority, particularly in comparison to other people. Self-deprecation, self-doubt, and marked discomfort during interpersonal interactions are characteristic manifestations of this syndrome. Self-consciousness and negative expectations about interpersonal relations are hallmark features of interpersonal sensitivity. And this dimension is elevated in cases of depression, social phobia, and syndromes of that nature. It really is the symptomatic version of Alfred Adler's inferiority complex. Again, more. Depression. So the depression dimension is the largest dimension of the SCL90 dimensions and reflects a representative range of the manifestations of clinical depression. Because of the high prevalence of depression and the variety of syndromes that comprise it, it reflects a wide range of symptoms, including dysphoric mood and affect, signs of withdrawal of life interest, lack of motivation, loss of vital energy, feelings of hopelessness, thoughts of suicide, and other cognitive and somatic correlates of clinical depression. Next we have anxiety, if I can get it, there we go. General signs of anxiety, such as nervousness, tension, and trembling, are included in the domain definition, as are feelings of apprehension, dread, terror, and panic. In addition, some somatic manifestations of anxiety are also reflected in the domain. Whoops. Hostility. The symptoms of hostility dimension include thoughts, feelings, and actions that are characteristic of the negative affect state of anger, and they reflect in all three modalities of expression. Qualities such as resentment, irritability, aggression, and rage. Let's see if we can get the next one. Phobic anxiety dimension is an interesting one. Defines a syndrome as a persistent fear response to a specific person, place, object, or situation, which is disproportionate to any actual threat and leads to avoidance or escape behavior. Items overlap highly with the DSM-4 agoraphobia syndrome. This came out of the work of some British psychopathologists at Newcastle. And their first paper on it, Kylo and Garside, 1959. So this whole agoraphobia syndrome is been with us for a lot longer than the DSM. Okay, the paranoid ideation dimension represents paranoid behavior as fundamentally a disordered mode of thinking. Items comprising paranoid ideation reflect the cardinal clinical features of paranoia, including projective thought, hostility, grandiosity, suspiciousness, centrality, and fear of loss of autonomy. And finally, the psychoticism dimension was designed to represent the construct as a continuous dimension from a withdrawn, isolated lifestyle at one pole to demonstrable psychotic behavior at the other. The measure attempts to reflect a graduated continuum from mild social alienation to first-rank symptoms of psychosis. And this conceptualization owes a lot to Hans Eysenk's work. Okay, let's see, the importance of norms. I can't emphasize enough how important I believe norms are. Raw score test scores are almost meaningless unless you've been working with an instrument for years and can interpret test scores. And even then, it's very difficult to assign meaning to them without good norms. So they're essential for standardized reporting, greatly facilitate interpretation and communication, greatly facilitate the evaluation of clinical change, in particular, enable within-profile as well as between-profile comparisons if they're done well, enable comparisons across gender or age through specifically key norm groups. Okay. Now, all the instruments in the checklist series use area T-scores for the norms. And area T-scores represent standardized, normalizing transformations that reflect the area or proportion under the normal curve associated with that score. This enables the assignment of an accurate percentile equivalent, which is really important when you're communicating with patients and patient families, because all of the Z's, T's, and et cetera are very esoteric. But percentiles, almost everyone understands. And again, facilitate interpretation both within and across profile. Use of standardized score like the area T, and this is opposed to the linear T-score, which is not normalizing, enables the development of gender-keyed norms and the possibility of meaningful comparisons between men and women. In the area of psychological distress and psychopathology, as I'm sure you're aware, you cannot just compare male scores with female scores. For whatever reasons, and there are many, females are much more dramatic in expressing their psychological distress. Now, the normative samples for the checklist series, and this just lists them, have community norms, psychiatric outpatient norms for some of the tests, inpatient norms, adolescent non-patient norms, and we do have an very good oncology patient norm for the BSI-18. Now, in addition to the 83 items that load on the 9 dimensions, there are also 7 configural items, and they help to interpret the syndrome that the patient is presenting with, although they don't univocally or solidly load on any of the 9 primary dimensions. One has to be careful because you could, with factor analysis, easily create a sleep dimension in the sense that we've got 3 problems with sleep and they tend to correlate. But clinically, that's not meaningful. Sleep that's restless or disturbed, trouble falling asleep, and awakening in the early morning are very different symptoms from a clinical perspective. So here are the configural items. Now, we use a tri-level interpretive model, and if I can get this to work right, we'll see it. There are 3 levels of interpretation of these instruments. The global score, and there are more than one, but primarily the Global Severity Index, provides summary information on overall respondent distress level in a single numerical value. Dimension scores provide information on specific areas of psychological distress and deliver a relative profile of the respondent's current distress experience. Item scores provide details concerning the specific manifest symptoms that are currently distressing the patient, and I'll show you an example of what I mean in 1 minute. Okay. Now, this is a profile from the Hopkins Sex Clinic, circa late 70s, early 80s. 137 men with erectile dysfunction and 110 women with orgasmic disorder. What we see are the men in red and the women in, I guess, lavender. And these profiles, the 50th centile line is down here. So what we see in the men is strong elevations of 2 standard deviations on depression and anxiety, and also, let's leave it at that, that are clearly in the clinical range. And the global score, the Global Severity Index here, is also just breaking through the clinical range. Now, the women do not have any dramatic elevations, although their whole profile is elevated a full standard deviation, as is their global score. But nonetheless, you get a sense, if this were an individual instead of a group, you get a sense of the sort of most pressing areas of distress and the possible areas of diagnosis. Okay, now, for the next level, I selected the items from the depression dimension on the 137 males with erectile disorder, and the rates of these items, symptoms, manifest in the men with erectile dysfunction versus the normative, the non-patient normal norm in the lavender. And you can see that they are, most of them, very highly elevated compared to the normals. So at the item level, again, if this were an individual, you would gain a lot of detailed information on their status. Okay, next we have, again from the sex clinic, slightly different time, profiles on 76 couples who, in whom the woman had a diagnosis of anorgasmia. At that time, I felt very strongly that we couldn't just assign a diagnosis of anorgasmia to a woman because patients were so different. It struck me that they had strengths and weaknesses and vulnerabilities that were so different from each other that just calling them anorgasmic was akin to saying, oh yes, they all have blonde hair, which was somewhat relevant, but didn't fully characterize them. So we used hierarchical cluster analysis, and we identified 4 syndromes, 4 anorgasmic syndromes. The first, the red, were highly symptomatic on the SL90R and had multiple psychiatric diagnoses. The yellow we identified as personality disorders, in large measure because there were 16 people in this group, and 11 of them had been diagnosed with histrionic personality disorder. Now, the other two were pretty much unremarkable in the sense that the green profile today would be diagnosed with hypoactive sexual desire disorder, but it was a diagnosis that didn't exist at the time these studies were done. They were anorgasmic. They were anorgasmic because they had no sexual desire, or relatively little. And the final powder blue profile were women that we labeled constitutional because we could find no problem for them. It was their nature, basically, to have difficulty achieving orgasm. So this was, I thought, very interesting and helped break away from the monolithic diagnosis of anorgasmia, which was only one small part of what was going on. Now, caseness is something that is important to establish, and with an inventory such as any of the instruments in the Diriganis checklist series, you'd like to have a caseness criterion when you're using the instrument to screen normal versus disorder. And so what I did here was to build a generic caseness criterion for the SEL90R. And basically it is a T-score on the Global Severity Index greater than or equal to 63. And we use the community norm of about 1,000 people and overlaid it with the psychiatric outpatient norm, and then did the specificity and sensitivity cuts. So you can use this if you don't have one that you've developed locally, but by all means, you should develop a local norm to do this. Okay, what do we have next? Now, common comorbidities and the SEL90R. An enormous percentage of diagnosable disorders have a triad of elements: anxiety, which may be the precipitant; depression, which is a maintaining factor; and somatization, which amplifies the distress the individual has. And it's kind of extraordinary how many of the conditions we see derive from this triad of conditions. And this is a study by Lowe and his colleagues in primary care. And this is particularly true in primary care, where you have more of the somatization component. So basically, you can see that while the prevalence rate of depression was 6.6%, 75% of those individuals had comorbid anxiety and somatization diagnoses, or both. For anxiety, 8%, but 57% of those individuals had comorbid depression, somatization, or both. And finally, those with a somatization diagnosis, 9.5, 54% of those had somatization and comorbid anxiety and depressive disorders. Now this, I'd like to share with you, sometimes the somatization dimension is sort of the forgotten little brother in these studies, and I took it upon myself at one point to, not too long ago, but to look at what an elevated somatization score would tell you. So I looked through studies where the t-value greater than equal to 6.9, which means 2 standard deviations above the mean, was the criterion for inclusion. And in the 90s, Wayne Caton did a lot of work in the general hospital with distressed high utilizers of healthcare. And a SEL90 score of 6.9 or higher very much predicted those individuals. As we just reviewed, high comorbidity with anxiety and depression disorders, moving by itself back, was also characteristic in a brief study. And this is very interesting, and I can't pronounce this investigator's name, Ringager or something like that. They had a chest pain clinic, and they had a grant that enabled them to follow for 9 years all the patients that presented to the chest pain clinic. This was actually a cardiology department. What they found was that in those individuals who had a somatization score on the SEL90 of 69 or above, there was a 5-fold increase in the diagnosis of panic disorder 9 years later. So I think that's very interesting. And then high psychiatric morbidity in environmental illness patients, that is, high levels of somatoform anxiety and depressive disorder. So this is a little hallmark that you can kind of tuck away if you're using these instruments and look for to see what it tells you. Now, predictive validity is something that basically is instrumental in measurement. If we can't predict to criteria, then we're not doing much good. This is one of my favorite studies. It's a British study. It's 30 years old, but still, I really love it because it demonstrates how sensitive these brief instruments can be. Pevlier and Fairburn had 2 samples, diabetic sample, which they call the medical sample, and a bulimic sample, which was psychiatric. They contrasted case finding using the SEL90R with the present state examination. Now, for those of you that don't know, the present state examination is a highly structured, very lengthy psychiatric interview, which can often take an hour to administer, and you need a clinician to do it. Whereas the SEL90R, it takes 12 to 15 minutes, typically. So what they did, they used the present state examination as a criterion, and they contrasted the predictive power of the SEL90R with the present state examination using ROC analysis, which is a regression, a logistic regression technique, without getting into the details of it. And what they found was the area under the curve was 0.90 in both samples, which is very good. You get a 1, that's the highest. Sensitivity, 88%, specificity, 80% in one sample, and sensitivity, 76%, and 92% for specificity in the other. They did logistic regression using the Global Severity Index against the present state examination and got good sensitivity and specificity coefficients. And then they did convergence, which I thought was really neat. The present state examination obviously has many categories of possible diagnosis. And what they found was that in the majority of categories, there was high convergence between SEL90 dimensions that were appropriate and the PSE diagnostic category. So I like that a lot. Now, this is a nice little study in which residual gain scores were correlated with retrospective outcome evaluation in group dynamic psychotherapy. Okay, and on the left, you see the correlation with the patient retrospective evaluation, and on the right, you see the correlations with the therapist retrospective evaluation. And what you see is that a substantial amount of the variance is accounted for, predicted by the SCL90R, more so in the patient evaluation than the therapist evaluation, but that's to be expected. So that's a nice little study that Jensen and colleagues did. Now, next study is another ROC analysis in primary care using the Global Severity Index and the Anxiety and Depression scores to show the predictive value of SCL90R against clinician diagnosis. And what surprised me was that the anxiety score did the best job of predicting with an area under the curve of 0.86, followed by depression, which is 0.81, and finally the GSI, which is 0.75. All of these measures have high predictive validity according to Schmitz and his colleagues. This is a neat little study in that it shows sensitivity to comorbidity, in this instance, with adolescent samples with anxiety disorder. So what these investigators, Esau and others, did was they had a number of cohorts of adolescents, starting with the red group, or the red line, who were free of psychiatric conditions. Next, the yellow line, who had an anxiety disorder. Then the green profile, who had an anxiety disorder plus an additional disorder. And finally, the blue line, who had an anxiety disorder plus two independent disorders they were diagnosed with. Now, the interesting thing is that you can just see a difference of the cumulative impact of these conditions on the patient's distress level. And until you get to the final one, which is much more dramatic, the profile shape stays very much the same. By the way, the differences between these profiles are statistically significant. So, I think that was an excellent demonstration of sensitivity of the 90. Let's see, who do we have next here? This was a study done by Mark Ketterer. Mark was one of my interns at Hopkins many years ago and lived to tell about it. This is a study where he cleverly correlated the SCL90R scores with age at initial diagnosis of coronary heart disease. And then he broke a sample down into patients with and patients without a diagnosis of major depressive disorder. And what you see, surprisingly, at least I was surprised, is that some of the SCL90R dimension scores correlate significantly with age at initial diagnosis in both groups of patients. There's not much difference between them. So again, another nice demonstration of sensitivity. of unique study that only a couple have been reported, probably because it's so much work to do, by Kopta and Joitler and a number of other investigators, on symptomatic recovery in psychotherapy as a function of dose of psychotherapy, that is, and symptom class. Now, the distinctions into acute, chronic, and characterologic symptoms were made by the investigators, and I would not venture a guess that I would agree with them on the assignments of all these symptoms. But nonetheless, they did. And they took a look at a resolution of symptoms by distress category across time. And this graph only goes to just a little short of 1 year, but they actually carried it a bit further than that. What you see is that, first of all, improvement is much more dramatic in the beginning of psychotherapy and levels off pretty dramatically, particularly with characterologic symptoms, as time progresses. And while I think, if I remember right, don't hold me to this, I think it took something like 11 weeks to get a 50% reduction in symptomatic distress with the acute distress group. But it took slightly over a year to get a 75% reduction. So you can see that this is heading, these improvement curves are heading for asymptotes fairly quickly. So the sense that your patients aren't improving quite as much over time is probably an accurate one in terms of pure symptomatic distress. This is a PSI study using the Global Severity Index on scores of methamphetamine addicts with and without baseline major depressive disorder at 3 years post-treatment follow-up. And what you see with the individuals that are free of major depressive disorder, that their improvement keeps gaining and gaining and moves into the normal range sometime before the 3-year follow-up. And by the 3-year follow-up, they're well into the normal range symptomatically, whereas the patients with major depressive disorder as well as methamphetamine addiction do improve at the same slope or rate, but then regress and by the end of 3 years are almost where they started from originally. So interesting and cautionary, I guess. Then we have a study with the VSI anxiety prediction of in-hospital complications in acute myocardial infarction patients using logistic regression. So they're looking at how well these variables predict complications, yes or no. And the variables that do, like, are to be expected, previous MI, smoking is marginal, taking an anxiolytic is significant. But by far the most significant variable is a score on the VSI anxiety dimension. So I thought that was very interesting and potentially very useful. Almost there. Now, this is just a study that I like because of the size. It's outcomes monitoring, and I'm very much in favor of outcomes monitoring. with these brief instruments. You can get so much information with so little investment of time and energy. And this is a Dutch study, and the normals are the dark bars, distribution of scores, and the patients are outpatients with anxiety, depressive, other conditions, and there are 5,100 of them in this sample, and 1,300 normals. So what you can see is that over time, these psychiatric conditions present and are manifest and can be reflected in a fairly simple assessment instrument like the SL90R, the BSI, or BSI-AT. Okay, so that's the presentation, and now we have a case example. Now, because we're moving along briskly, I won't have time to go into a lot of the detail about this, but this is an SL90R profile generated by the Pearson, and the Pearson folks can tell you precisely which report this is, but it's a 27-year-old female patient. She presented